and in today's session I'm going to discuss about trigeminal neuralgia and its management. Trigeminal nerve has both sensory as well as motor component. That is, it takes sensations from the face to the central nervous system as well as apply motor function to the four muscles of mastication. That is, masseter, temporalis, lateral and medial pterygoid. There are four nucleus associated with trigeminal nerve. One is the primary sensory nucleus, the other is the spinal nucleus, the third one is mesencephalic nucleus. All of these three nucleus are sensory nucleus and the fourth one is a motor nucleus. Now, what happens is that it has three main divisions. Okay, that is, one is the ophthalmic division, the second one is the maxillary division, and the third is the mandibular division. Ophthalmic division take the sensation from the upper eyelid, from the eye and the frontal area towards the central nervous system. Whereas the maxillary division take the sensation of touch pain from the maxilla, the lower eyelid, the nose, the gums of the maxilla, zygomatic bone towards the central nervous system. Whereas the mandibular division takes sensations from the lower lip and the mandible, lower gums towards the central nervous system. So as I said earlier, there are three main branches of trigeminal nerve that we need to know. And any disturbances of any of these branches can affect the nerve directly. Let's move on to the definition. Neuralgia, by definition, is nothing but pain in the distribution of nerve. Thus, trigeminal neuralgia is defined as sudden, usually unilateral, severe, brief, stabbing, lancinating, paroxysmal, recurrent pain in the distribution of one or more branch of trigeminal nerve. It is also termed as tic doloris. It means that painful jerk. Okay, it has arise from the term painful jerk because in this condition muscle contraction takes place simultaneously. Thus, it is also termed as tic dolorex. It is also known as by the name of Fotokil's disease. This is because John Fotokil was the first one who described in detail about the clinical presentation of trigeminal neuralgia. Let's move on to its etiologies. Trigeminal neuralgia can arise because of granulomatous and non-granulomatous infection involving any of the division of trigeminal nerve. It is also associated with multiple sclerosis. It is said that a sclerotic plaque near the root of the trigeminal nerve can bring about neuralgic changes. It can also arise because of compression from the petrous ridge in the temporal bone. So you need to decompress the ridge by trimming the ridge and relieve the neuralgic pain. It can arise after the trauma. Any kind of injury to any of the divisions of trigeminal nerve can result in post-traumatic neuralgia because of formation of post-traumatic neuroma. It can also arise because of intracranial tumors or intracranial vascular abnormalities that presses on to the root of the nerve, resulting in trigeminal neuralgia. It also arises from herpetic herpes zoster virus infection, which is termed as post-herpetic neuralgia. Thus, it has a multifactorial origin. Let's move on to its pathogenesis. It is stated that initiation hypothesis explained the pathogenesis of trigeminal neuralgia. Now, this hypothesis is based on abnormal electrical behavior in injured sensory neuron. Now, because of this abnormal behavior, specific abnormal trigeminal efferent neuron in trigeminal ganglion, there is some abnormality is seen. Now, because of this abnormality, this results in axon hyperexcitability, which give rise to pain paroxysmal as a result of synchronized after discharge activity. Now, what do you mean by pain paroxysmal? Pain paroxysmal is recurrent and stereotype pain that occur again and again. That is termed as paroxysmal pain. Let's move on to its clinical features. It is seen in 4 in every 1 lakh of person. More commonly in the middle age, that to females are affected more than the male, and the ratio is around 58%. Now, it is seen that right side of the face is affected more commonly, around 60% compared to the left side. And you see the distribution of the nerve. The mandibular nerve is affected more than the maxillary nerve, then the ophthalmic division. Let's move on to its classical clinical characteristics, which is pain. Pain is of severe lancinating pain, throbbing pain, shock-like pain. okay, radiating on the face. The pain is such that the patient cannot bear and clenches the hand on the face and start to rub the face. It is so painful. The duration is short-lived. It is for a few seconds, then it stops and it recur again. Whenever it recurs, the frequency is variable, and it is said that as it starts recurring, the intensity keep on increasing. Now it is also associated with a specific trigger zone. Now these trigger zones are sensitive points along the divisions of trigeminal neuralgia. Okay, if it is associated with maxillary division, your specific point is your lower eyelid, your nose and the upper lip or upper gums. Okay, if it is associated with the mandibular division, your trigger zone could be lower lip, then it could be the gums of the mandibular teeth. If it is associated with the ophthalmic division, which is very rare, it is most commonly supraorbital ridge. The pain is so much that any slight touch or minimal mechanical trauma or any kind of minimal mechanical touch in that area can start severe lancerating throbbing pain. It is so severe that the patient don't even brush in that area, resulting in very poor oral hygiene. The patient fear to shave in that area. In severe cases, the patient don't even try to move the face, and the condition is termed as mask-like face. Now the attack, the classical feature is that they have a refractory period. There is pain, there is a period of refractory period when there is no pain, and then after a few months or a year there is pain again. The attack do not occur in sleep. This is one of the clinical features that you can distinguish with other type of pain. Now your diagnosis ultimately depend upon complete case history and classical clinical pattern of the pain will help you to do the diagnosis. Now Sweet has put forward 5 major diagnostic criteria. Now these are paroxysmal pain, pain provoked by light touch on the face, that is the trigger zone, pain confined to trigeminal distribution, pain is unilateral, and clinical sensory examination is normal. Okay. Then we move on to the other diagnostic aid. When a neuralgia is present in young, you need to do an intracranial examination, that is a CT scan or an MRI is a must, because most of the time it is because of intracranial lesions like a tumor or a vascular malformation. Then, now these patients respond to tablet carbamazepine. Any other pain in the face is not treated or it does not respond to carbamazepine. But if this facial pain responds to carbamazepine, then it is termed as a neuralgic pain. It is one of the treatment modality as well as a diagnostic aid. The other diagnostic aid is use of diagnostic injection like local anesthesia. When you inject local anesthesia along the trigger zone, the patient has marked relief. It provides temporary relief to the patient as well as act as a diagnostic aid. Let's move on to the treatment of trigeminal neuralgia. The treatment of trigeminal neuralgia, the gold standard is the medical or conservative management. It begins with the use of anti-epileptic drugs. Now, why anti-epileptic drugs? Now, in trigeminal neuralgia, there is a pathologically abnormal activity of neurons which give out unexpected signals from the periphery towards the central nervous system. The same thing happens in seizures or epileptic patients. That is the reason why anti-epileptic drugs are a treatment of choice in case of trigeminal neuralgia. Now the drugs that are used are most commonly is carbamazepine. The brand name that we are aware of is Tetratol. It is around 100 milligram. You have to give 3 times a day. You could increase the dose to 1000 to 1500 milligram per day. Other drugs that can be used are phenytoin 100 milligram a day 3 times a day, valproic acid 600 milligram 2 times a day. In patients who are contraindicated with carbamazepine, you can give clonazepam 1.5 milligram per day. There are less toxic drugs are also available like baclofen 10 milligram 3 times a day and gabapentin 300 milligram 3 times a day. Now the maximum dose that can be given is around 2500 milligram. Okay, but one thing that you need to keep in mind is that when you are treating the patient with anti-epileptic drug, you have to do a thorough blood count profile and liver function test, because these drugs affect the blood count, they affect the platelet function, they actually causes bone marrow suppression, so they may cause leukopenia, thrombocytopenia, so that you should have a proper blood profile as well as liver function test. So you need to do it before you start the treatment, 1 month after the treatment, and 3 months, every 3 months when you're giving a higher dose of more than 1500 milligram. there are certain side effects associated with it, like blurring of vision, you have tinnitus, you have vertigo, sometimes you have rashes. These are few disadvantages that are associated with it. And now if what you could do is that if the side effects are more, there is something called as multi-drug treatment of using anti-epileptic drug. It is said that each anti-epileptic drug have a different mechanism. So what happens if you are having adverse effect with one drug, you add another anti-epileptic drug to it. This will increase the therapeutic effect as well as decrease the discomfort or decrease the side effect. But if you're already giving two different type of anti-epileptic drug and still the side effects are present and the pain is also present, there is no need to add another drug. Then you have to look for another treatment alternatives. Alright. Then you can move on to the other treatment modalities, that is peripheral nerve injection. Now these are basically given to localized area of trigger zone. You start with local anesthetic injections like bupivacaine with corticosteroid. Now the effect of this is very short-lived till the effect of the local anesthesia. This you could use as a diagnostic measure as well as an emergency procedure as soon as when the patient comes to your clinic and the patient is in severe pain. You can use this. The other alternative to this is local injections of alcohol. 5% alcohol, you could inject 0.5 to 2 ml. Okay, now alcohol, it is actually, you cannot give multiple injections. Though its result is good, the pain relief is for 6 to 12 months. But if you give multiple alcohol injection, it will cause local tissue necrosis. It will cause fibrosis of that area. Okay, so you should avoid it. Once or twice it's okay. You could give block in the infraorbital, you could give block in the mental, you could give your block in the inferior alveolar nerve. But multiple injections should be avoided. Alright. Then the other is the use of peripheral neurectomy. Now peripheral neurectomy, it acts by decreasing all the efferent activity from the periphery towards the central nervous system. As the name suggests, there is nerve avulsion. You're actually removing the nerve. So you're removing the peripheral nerve, so the sensation does not go towards the central nervous system. Now its indication is in those patients wherein more craniotomy procedures or extensive procedures are avoided. In that case, you could do a peripheral neurectomy. Disadvantage is that it causes complete anesthesia of that part of the face. Now, eventually, nerve regrow and neuroma develops, which will result in pain. That result around after a year or 3 years or 2 years. Let's move on to each of the neurectomy procedures. Now, this neurectomy you could perform both in the intraorbital nerve, inferior alveolar nerve, and lingual nerve. We will see the procedure that is done in case of an intraorbital neurectomy. It could be either an intraoral conventional approach or a bronze transantral approach. Now an intraoral conventional approach is through a cardiac incision. Okay, in the canine fossa region you will give a mucosal incision, U-shaped mucosal incision, reflect a complete mucoperiosteal flap till you find the intraorbital nerve. You'll tie a linen around the intraorbital nerve. As soon as you'll tie 2 linen around the nerve. Between the 2 threads, you will cut the nerve and cauterize the nerve. Okay, then the distal end is try to pull from the skin and the mucosa. You literally try to pull and avulse the nerve from the skin and mucosa. That's the reason why this procedure is done with general anesthesia. Okay, once you have removed the peripheral nerve, then you will remove the more proximal nerve root, that is from the foramen. You will pull it from the foramen. In this way, you will remove the nerve from the foramen as well as from the periphery region. The other transantral approach is that through the same cardiac incision, we enter into in case of the conventional approach. But in this transantral approach, you give a mucosal incision in the maxillary buttress region so that you try to expose the anterior lateral wall of the maxillary sinus. You will create a 3 mm window in the wall. Once you have created the window in the wall, you will separate the mucinous lining and you see the posterior wall of the maxillary sinus. You will create a hole in the posterior wall of the maxillary sinus, or you create a window. You will try to trace out the descending palatine nerve. Now, as this descending palatine nerve will move superiorly to the sphenoid ganglion. Okay, in this way you will trace the nerve and you will cut the nerve posterior to the sphenoid ganglion, sphenopalatine ganglion. That is, as soon as the nerve comes out from the foramen rotundum. The alternative method is that as soon as you have created a window, try to come over to the roof of the maxillary sinus, wherein you will find the infraorbital canal in the nerve. You trace the nerve back to the posteriorly and superiorly till the maxillary nerve root. That is, as soon as it try to comes out of the foramen rotundum and cut posterior to the sphenopalatine. The disadvantage of this technique is you're also cutting the branches that are coming out from the posterior part of the sphenopalatine ganglion, which you need not want to do that, but you have to cut it. It is more cumbersome procedure, very surgically sensitive procedure. Lot of bleeding can take place. You need to have a microscope to visualize what you're doing. There are chances of bleeding from the posterior pterygopalatine fossa can occur. So excess of bleeding will decrease your visibility. So it's very technique sensitive procedure. That's the reason why the intraoral conservative approach is more preferred over the transantral approach. Let's move on to the inferior alveolar nerve neurectomy. Here also there are two approaches, extraoral approach and intraoral approach. Now, in case of extraoral approach, you will give a submandibular resistance incision. You will come to the inferior border of the mandible, strip the masseter muscle, expose the buccal cortical plate. You will create a window in the buccal cortical plate, and with the help of nerve hook, you will try to hold the inferior alveolar nerve. And then you will put two linen thread on the inferior alveolar nerve. You will cut the nerve between the two linen thread, cauterize the end and pull the linen thread. Okay, so pull the linen thread from both from the canal and from the anterior region. The another alternative to this, which is a better approach, is an intraoral approach given by Dr. Jinwala, also termed as Jinwala's incision. Now in this, you will give a Y-shaped incision starting from the anterior border of the ramus, and the fork of the Y is towards the buccal and the lingual aspect. Okay, once you have done this, you will try to do a medial dissection, expose the entry of the inferior alveolar nerve near the lingula. Okay, there you will tie two linen threads. Okay, before the nerve enter the foramen, you will tie two linen threads. Then you will cut between the two linen threads and cauterize the end. And the most proximal end is pulled out. Okay, the other distal end towards the lingula is still attached to the linen thread. Now this linen thread you will catch hold with a hemostat and keep it aside. Then you will give a vestibular incision in the mental foramen region. You will expose the mental nerve. As soon as the mental nerve comes out from the inferior mental foramen, you will tie a single linen thread and cut the nerve just posterior to the linen thread. Okay, now you will hold this linen thread through a hemostat and try to pull the peripheral branches of the mental nerve from the skin and the mucosa. You will see puckering of the skin near the chin region. Alright, after you do this, then you have already kept a hemostat attached to the proximal end of the inferior alveolar nerve. You will try to pull that inferior alveolar nerve through the entire inferior alveolar canal and remove it completely. Next, we move on to the lingual neurectomy. It is a very rarely done procedure since the nerve is very rarely involved. In this case, you will give an incision from the anterior border of the ramus starting till the floor of the mouth. You will try to do a medial dissection and expose the nerve medial to the ramus. That is, the nerve will be medial or lateral to the medial pterygoid muscle. Then as you come to the floor of the mouth, the nerve is more superficial and easily identified. Once you have seen the muscle, you will hold it with a nerve hook, try to cauterize and remove it avulse it from the floor as well as from the superior limit. The other treatment is cryotherapy or cryoneurolysis. Now in this technique, there is direct application of cryotherapy probe at -60 degrees Celsius. Now this is said to be causing Wallerian degeneration without destroying the nerve sheath. Now how do you do this? You'll put the probe for 1 to 2 minutes, then you will wait for another 3 minutes and then you again put the probe. Now this is done in 3 times. Okay, the result lasts for around 3 to 6 months, but eventually nerve regeneration takes place and pain will recur. The other or more extensive treatment modality is the intracranial procedure, that is the posterior fossa decompression. Now, posterior fossa decompression is an open craniotomy procedure in which you will do an open craniotomy to expose the nerve root of a trigeminal nerve, and then you will visualize the main thing, that is what is compressing over the trigeminal nerve. Most of the time there are either tumors or vascular lesions that may be associated with superior cerebellar artery. There could be an aneurysm associated with superior cerebral artery which is compressing onto the root of the trigeminal nerve. So what you will do is you put a non-absorbable material between the aneurysmal superior cerebral artery and the root of the trigeminal nerve, like a Teflon wool. You'll keep that so that compression is less. Okay, now once this procedure, around 80% of the pain decreases in 80% of the patient, and it does not occur for around 5 years. So 5 years the patient is pain free. But this procedure is very technique sensitive. The mortality rate is around 2%, and sometimes some neurological damage can occur if not done properly. So now these conditions cannot be attempted in medically compromised patient or an older age patient. Thus, with this, I would like to conclude by saying that trigeminal neuralgia has been an enigma to physician. Various advances are made regarding its pathogenesis per se and treatment modalities, but not one single treatment modality is effective. Thus, the gold standard still remain an optimum scrutinization and authentic diagnostic, which is always the key of success for any treatment.